नमस्कार, मैं हूं प्रीति झांगियानी and today I'm here with Dr. Raman Kumar. He's one of the pioneers of family medicine in India. तो रमन जी, मैं आपसे ये पूछना चाहती हूँ, फैमिली मेडिसिन में आप पायनियर माने जाते हैं, तो कैन यू टेल अस अ लिटिल अबाउट योर जर्नी और आपने यही प्रोफेशन क्यों चुना?
Thank you, Preeti ji. Thank you very much. And as you introduced me as a pioneer, but I would say I'm just trying to bring back the concept of family doctors.
Yes.
The one which is, we all know, everybody has a family doctor. We have all seen family doctors in our lives. But professionally, this tradition was on decline. If you look around, big cities like Mumbai, Pune, Delhi, the older generation of family physicians was retiring. They are in their 70s and 80s. In Mumbai, we have our old friend, Dr. Ramnik Parekh.
Yes.
He's in 80s. So the new generation of family doctors were not coming up because the career pathway of family doctors was not structured within the medical education system. But I come from a small town in Bihar. I came to Delhi for my post-graduation. Now I'm settled here in this part of NCR. And somehow, from my upbringing, I was inclined towards becoming, like everybody else, the most famous doctor of my city town. And when I heard about family medicine specialty, its training program in Delhi, it was natural for me to, choose for this discipline, this career pathway, because it suited my temperament and my aspirations to become a doctor in my life. And I thought that it is much helpful if I become a family physician to the society than a hospitalist or hospital specialist.
Correct. But can you explain to us what exactly is family medicine? How is it different from other specializations?
Right. So in MBBS course, we have, around 20 specialties. We read 20 books, subjects in MBBS, but you have to opt for any of these 20 after your MBBS, and we go through NEET postgraduate examinations. And then according to your maiden choice, you get into these specialties. But the number of specialties is very less as compared to the MBBS seats. We make around 100,000, 1 lakh MBBS doctors a year. But the number of postgraduates is around half or even less. The clinical ones where you see patients are even lesser. So there is always a challenge in the career decision of MBBS graduates. And family medicine is different from other specialties because family medicine is largely community based. So when I practice family medicine or when I'm practicing as a family physician, I practice in a community, not in a hospital. So hospitalists are different. They have different protocols of treatment. They would treat emergencies, intensive care and things like that. But I treat all age groups, all genders, all organ systems in the community, all common problems. And research has shown that 90% of the common problems can be seen by a family physicians. And we do not need hospitalizations or hospital treatment for all problems.
Yes.
And as you say, in India, we have overcrowded public hospitals, government hospitals.
Correct. That certainly is an issue.
Yeah. So that is the difference of family medicine, and it is largely community based, and we provide comprehensive care to all age groups, as I said, all genders, irrespective of organ systems. So I'm not a doctor of, say, eye or posterior chamber or, bone or any part of body, but I'm a whole person doctor.
Right.
When people ask me what is your specialty, I'm a whole person doctor. I'm a life cycle doctor. I see patients from pediatric age group to geriatric age group, from what we say cradle to grave, from beginning of life to end of our life care. So that is different from other hospitalists because they say only one organ. As you know, in hospitals, it is fragmented.
Correct.
In community, we see all kind of patients, which is, undifferentiated. This is the basic difference.
Right. But in today's healthcare scenario, why do you feel that family doctors are so important?
Yes, especially if you see after COVID pandemic, everybody wanted that. They wanted to talk, at least, make a call to a doctor, which was not available at that time.
Correct.
And going to hospital was difficult and even not preferred by doctors, not by doctors, health institutions, but also by common people. They did not want to go to hospitals. So at that time, at home, even when the home services or home care for COVID was allowed, who would take care of these patients at home when the problems are multiple types? So one specialist cannot take care, one respiratory physician, one intensive care physician cannot take care of patients at home with multiple problems. So family physicians at that time, people also realized was important that we need someone who we can trust, who can guide us through this kind of dilemmas of treatment, what to do, what not to do, what to eat, what not to eat, kind of things. This happened especially during COVID period. And then onwards, we have seen that there's a lot of interest within the government, also in the community and people for family physicians services in the society.
Correct. But still we see that people still want to visit specialists first.
Yes.
Why do you feel that it's so important that they see their family specialist first before their family doctor physician first, rather than go directly to a specialist?
Yes. So this is a cultural trend. I would say since 70s and 80s, we had large multi-specialty hospitals, big names across all cities, all metropolitan cities. And now the trend has become that you have headache, you go to neurologist, you have the gas problem, you go to gastroenterologist.
Yes.
But I give you one example of headache. Like, common sense, headache would mean that, you should go to your neuro brain specialist. But practically, when we see what could be the causes of headache, then we see that, it could be because of hypertension, which is not a neuro problem.
Yes.
It could be because of dental issues. It is not a neuro problem. Then again, it could be because of vision problem. It is not a neuro problem. Then it could be because of high sugar levels, lack of sleep, stress. All these problems are not necessarily neuro problems. So going only by common sense, as people go, you'll go to a neurologist, get an MRI done, and you say that no, this is a dental problem or eyesight problem, and then your the cost consultation is waste because the problem is not resolved. So better to go to your family physician who is well versed with all these kind of possibilities. And many times these problems are small. Like I've seen people come and we check their blood pressure, it is high, the sugar is high, they may have dental problems. We diagnose them and we guide them properly. And 90% of the times, as I said, we can resolve those problems by ourselves without a lower cost. At much easier, hospital is always difficult, different, and also costly affair.
Right. So I know you've already answered this question a bit, but still I'd like to ask you specifically, how is it that a family physician treats differently and is better to go to your family physician first? And how does he look at the matter a little differently rather than going to a specialist immediately?
So when we look at medical colleges or big hospitals, the kind and profile of patients that visit big hospitals are different. What we are trained on in medical schools is very different than what we see in community. I'll give you an example of, for example, we also see in our small clinics trauma or injury, but those traumas are different. Like, finger prick injury, something, small bruise, child fallen from the bed, old person fallen in the bathroom, somebody, small injuries, those can be treated at clinic itself. But if you go to a trauma center like AIMS, you would say big, fractures, unconscious patients requiring ICU care. Similarly, hypertension is different in community because, like, somebody comes with, headache, for example, as we're talking, and we check and the blood pressure is 220 by 110. Then this person is not having any symptom, only headache. If you go to a emergency department, you would be admitted. Many times you may be taken to ICU for observation, admitted for 2, 3, 4 days. But all these patients can be treated many times in community without any higher level of intervention. And our approach is different because common problems we can treat ourselves, and a number of patients we can deal by ourselves, all specialties.
Yes.
So that is advantage of going to a family physician rather than going directly to a hospitalist, where mostly these days the treatment is procedure oriented. You get your endoscopy done, then you get your treatment, you get your test done, then you get your treatment, you get an MRI, all kind of scans, and then you go for the treatment. But in family physician practice, our investigations levels are very low.
Right.
Our threshold for sending for hospital admission or for sending for a test is very high. I mean, we do not normally go for test. We would diagnose clinically most of the time. We will talk to the patient, and many times, it's a history. When we talk, have a conversation, we diagnose and we treat accordingly.
Correct. So definitely I can see that having a family physician improves the overall health and well-being of the family. Would you like to elaborate on that?
Yes, because we treat all family members. When people come to us, I mean, Some woman comes to us, they will bring their children with them. Husband also comes. Many times elderly people are also accompany.
Right.
And at times, they may also talk about, smoking problem with the husband, or eating habits of the children, or some, vision or some skin problem of the elderly. And many times it is all family which is getting consultation. And each family is unique in terms of, you see, their food habits, their, lifestyle, and the kind of work and occupation they are
Yeah.
engaged in. And then it is important that we treat family also, because unless you change the diet, you cannot treat the person.
Yes.
Unless you change the lifestyle of the entire family, you cannot change the.
Correct. Very
you know,
true. Very true. Very true.
So that is, the difference, or I would say the importance of treating the entire family, engaging the entire family in the treatment plan. It is not just one person, but the entire family, all age groups.
Right, right. So I think we've certainly understood how important it is to have a family physician and to visit your family physician first, whenever you feel anything, but to have one in continuity. Is there any example that you can give us? I mean, we've heard everything, but when if you could give us a good example of how having continued care by a family physician has helped a family.
Yeah. So many conditions are long-term conditions, like diabetes, for example. So once diabetes sets in, it requires decades of treatment follow-up, and more better the compliance on both parts, from the doctors as well as providers, as well as from the patient's part. The complications can be prevented. The damages to the other organs can be prevented. Similarly for hypertension, hypothyroidism. So here continuity of care is important, because the diabetic person is coming to the same doctor again and again, and then the same person may have other problems also. Suppose a diabetic is having viral fever or pneumonia or any kind of wound or injury. The same person can consult the same doctor, and then the one provider is knowing the entire history or background of the patient, and knowing also the family background of the patient, what is the income level, what is the community setting of the person. It is easier to diagnose and resolve without sending to a hospital or intervening at a much bigger level. So continuity is important, because same person is coming to you again and again for different problems.
Correct.
So you are treating same person. We have started treating children. They have grown up, now going to colleges. The people who were working earlier, now they have gone into their retired age. So, different age phases will have different requirements in their lives, and then we treat them accordingly. And this is what we understand as continuity of care is important for
Correct.
person's well-being and overall better outcomes of the health.
So, can you also tell us what role family doctors would play in preventive care and health education, especially for children and the elderly?
Yes. So, I'll give the example of elderly
Yes.
first.
Yes.
Elderly are at many risks, because they have declining in their physiological capacities, mental capacity, their orthopedic bones are getting weakened, muscles are no longer stronger. I'll give you one example. Many elderly people fall in their bedrooms or their bathrooms. They get their hip bone fractured or broken. So that is entirely preventable. We take it as normal कि bathroom में गए थे, गिर गए, टूट गई हड्डी. But if you take preventive measures like having proper light, proper flooring and tiles, footwears and bells, and something to hold in the bathroom, some support system, and somebody to supervise, take care of, simple things like denture. People talk about nutrition of the elderly, but if their teeth are not well kept and they are not able to chew food, they will not have good nutrition irrespective of what you feed them. So these are the preventive things from the elderly point of view. Children nowadays, we see a lot of, two things are important. One is their food habits. They're not ready to eat normal Indian kitchen food. They are always wanting to eat something from outside. And also nowadays on social media, mobile and social media, and they're always on their phone, mobile, laptops, even school-going children. So there are the areas where we can intervene, and even parents, when they come, they ask us to guide them,
Correct.
Counsel them, and then we try to engage them and tell them, convince them. When smaller children listen to the doctors, because they would not listen to their parents. So those are the scenarios which are out of context. Even when we are doing routine consultation, somebody has come for fever, but they will also ask regarding their children food habits, and we do that all the time for counseling, for prevention. And also a lot of people do these days preventive health checkups, and when they do the test, there are hundreds of parameters readings, and they are worried कि मेरा तो यूरिक एसिड बढ़ गया, SGPT बढ़ गया, ट्राइग्लिसराइड बढ़ा हुआ है, मेरा होमोसिस्टीन बढ़ गया है. Many times these concerns are not founded on scientific basis, and they are worried at times कि कैंसर तो नहीं हो गया, इसमें नीचे लिखा हुआ एक्सप्लेनेशन कि कुछ और प्रॉब्लम, हार्ट की प्रॉब्लम तो नहीं हो जाओगी. अभी जैसे रिसेंट कुछ इवेंट्स वगैरह होते रहते हैं कि किसी की सडन डेथ हो गई तो लोग परेशान हो जाते हैं कि मुझे यहाँ पे पेन हो रहा है, ये हार्ट अटैक तो नहीं हो जाएगा. काइंड ऑफ कंसर्न ऐसे होते हैं लोगों के. तो ये सब चीज़ें होती है, तो हम उनको बताते हैं अपने एक्सपीरियंस से कि ये नॉर्मल है या नॉर्मल नहीं है. और इसमें जितने भी डार्क आपके ये हाईलाइटेड रिपोर्ट्स है, not all are diseases, because not everybody is 180 centimeter.
Yes, of course.
सबका ब्लड प्रेशर 120/80 नहीं होता है.
बिल्कुल.
तो उनको हम बताते हैं कि दिस इज नॉर्मल फॉर यू.
जी.
तो ऐसे हम उनको गाइड करते हैं सो दैट पीपल आर नॉट एट ईज. एंड व्हेनेवर देयर इज अ प्रॉब्लम, अगर सच में किसी को हार्ट अटैक होता है तो बताना पड़ता है, किसी को कैंसर है तो बताना पड़ता है, बताते हैं और उसको ट्रीट भी करते हैं.
जी बिल्कुल.
बट नॉट नेसेसरीली कि उसके डर को, फियर को हम एग्रीवेट करें और उसको और ज्यादा उसको फीड करें.
बिल्कुल.
और इस चीज से हम उनको बचाएं, क्योंकि अभी सोशल मीडिया पे काफी ज्यादा लोग वरीड हो जाते हैं, गूगल में सर्च करके वरीड हो जाते हैं कि अच्छा मुझे पता नहीं क्या हो गया.
यस, ChatGPT इज द न्यू
जैसे गूगल डॉक्टर.
जी बिल्कुल बिल्कुल बिल्कुल. Certainly. So family medicine is very well established in the UK, US and in Canada as well. Can you tell us where India stands in this journey right now?
So if you look at UK, where NHS, National Health System, is there, without going to a GP, general practitioner, you will not go to a hospital or a specialist. And
I
the
didn't know
GP is
that.
the first portal of any kind of health problem, whatever problem, except for the accidents, major accidents, where you can go directly to the emergencies.
Correct.
Even it is longer duration. Even if you fracture of finger, you will have to wait for 3 hours in hospital emergencies in UK. India, many things are good because we are able to serve volumes, such a huge population. But here we do not have any filtering or kind of screening and what we call triaging of patients in the community. Everybody can go to anywhere. Like anybody having fear of having fever or any heart problem, go directly to a cardiologist. And many people here in Delhi would especially want to go to AIMS.
Yes.
And यहाँ पे तो वो बहुत चलता है कि लोग जाते हैं, बहुत सारे दूर दूर से लोग आते हैं. They will come and go to their ministers and member of parliaments कि we want to go to see a doctor at AIMS. And इसके लिए काफ़ी इसमें ये चलते हैं, मतलब जैक्स और ये लोग कोशिश करते हैं फ़ोन करवा के कि हमें देख लिया जाए. और इसकी वजह से जो जेन्युइन पेशेंट्स होते हैं, जिनको एम्स में या बड़े हॉस्पिटल्स में दिखाने की जरूरत है, दे आर नॉट एबल टू गेट द राइट केयर, और इट इज़ ओवरवेलमिंग फॉर द डॉक्टर्स, और इट इज़ ओवर क्राउडेड. सो इन इंडिया में थोड़ा सा ये डिफरेंट है, क्योंकि यहाँ पे पॉपुलेशन बहुत ज़्यादा है. इफ़ एवरीबडी गोज टू अ हॉस्पिटल देन द कॉस्ट इज़ वेरी एक्सपेंसिव. सो देर आर 2 टाइप्स ऑफ ट्रीटमेंट. जो झुग्गी वाले हैं और बिल्कुल जो लोअर इनकम ग्रुप के लोग हैं, दे आर डिपेंडिंग इंटायरली ऑन क्वैक्स. जो नॉन क्वालिफाइड पर्सन हैं. जो वेरी हाई एंड वाले हैं, हमें लगता है कि उनके पास इंश्योरेंस है, पैसा है, तो वो अच्छा इलाज करा लेंगे. उसमें भी रिस्क है, क्योंकि अगर पास इंश्योरेंस है एंड यू गो टू अ हॉस्पिटल, अगेन यू गो इनटू द सेम साइकिल ऑफ डूइंग द MRI, एंडोस्कोपी, विच वी कॉल ओवर डायग्नोसिस एंड ओवर ट्रीटमेंट. क्योंकि यहाँ पे कोई रेगुलेशन वैसा नहीं है कि बीच में कोई थर्ड पार्टी नेगोशिएटर नहीं है उसको वॉच करने के लिए कि आपका जो ट्रीटमेंट हो रहा है वो सही हो रहा है, या जितना होना चाहिए उतना ही हो रहा है. जैसे अभी कॉमनली होता है ना कि आईसीयू में रख दिया है, क्यों रख दिया है, वेंटिलेटर पर डाल दिया है, डालना चाहिए था कि नहीं, काइंड ऑफ थिंग्स, ऑल काइंड ऑफ दिस डिस्कशंस आर कॉमन डिस्कशन. पीपल आर डिससैटिस्फाइड विद द हॉस्पिटल्स.
करेक्ट.
तो ऑल्दो हमारे पास सिस्टम्स अच्छे हैं, बट उनको हमने ऑर्गेनाइज ठीक से नहीं किया हुआ है. अगर हमारे पास इंडिया में 1 लाख डॉक्टर्स हम बना रहे हैं, अगले कमिंग ईयर्स में 10 लाख डॉक्टर्स होंगे, अगर वो कम्युनिटी में काम नहीं करते हैं तो हॉस्पिटल्स में भी तो कोई ऐसी बहुत ज़्यादा रिक्वायरमेंट नहीं है. ओवर वहाँ पे सब्सक्राइब्ड है लोग भी और वहाँ के डॉक्टर्स भी. तो जो डॉक्टर्स हम बना रहे हैं, सिमिलर नंबर्स बाहर से आ रहे हैं, फिलीपींस, चाइना से, रशिया, यूक्रेन से पढ़ के आते हैं. तो वो लोग क्या करेंगे यहाँ पे? और पॉपुलेशन हमारी 1.5 बिलियन है, तो उनको तो हमें हेल्थ केयर देना है ना, हाई क्वालिटी हेल्थ केयर देना चाहिए.
बिल्कुल बिल्कुल.
हमारे प्राइम मिनिस्टर बोलते हैं कि हमें इंडिया को डेवलप्ड कंट्री बनाना है बाय 2047, विकसित राष्ट्र बनाना है. तो उसमें जो हमारा प्राइमरी केयर है, जो कम्युनिटी बेस्ड केयर है, वो भी तो हाई क्वालिटी होना चाहिए. यूएस, यूके, ऑस्ट्रेलिया, न्यूजीलैंड जैसा. वहाँ पे जो लोगों को एक्सपीरियंस होता है हेल्थ केयर, वन ऑफ देम इज कनाडा. भी मैं गया था यूनिवर्सिटी ऑफ टोरंटो में एक लेक्चर के लिए. तो वहाँ पे मैंने देखा कि काफ़ी अच्छा उनका सिस्टम है। तो वो सेम सिस्टम इंडिया में भी पॉसिबल है क्योंकि हमारे पास ह्यूमन रिसोर्स है,
बिल्कुल
और
बिल्कुल,
हॉस्पिटल इंस्टीट्यूशंस भी हैं। तो
राइट,
उसे हमें रीओरिएंट करना है इन अ वे दैट कि फैमिली डॉक्टर सिस्टम्स या फैमिली फिजिशियन सिस्टम जो कि पर्सनलाइज्ड हेल्थ केयर गाइड्स होते हैं। लाइक इफ यू गो टू ए जिम, आपको एक पर्सनल जिम ट्रेनर चाहिए होता है, आपको एक न्यूट्रिशनिस्ट एक्सपर्ट चाहिए होता है, लेकिन हेल्थ में आपके पास कोई ऐसा नहीं।
राइट। आई थिंक ये तो हम जान ही गए हैं कि इंडिया में काफी चैलेंजेस हैं
जी
फैमिली फिजिशियन केयर प्रोवाइड करने के लिए टू हियर इन इंडिया कंपेयर टू द अदर कंट्रीज। एनी अदर challenges you would like to elaborate on which we face in India?
कुछ तो इसमें लीगल एंड रेगुलेटरी प्रॉब्लम्स है। मेडिकल एजुकेशन सिस्टम जो हमारा है, इट इज़ लार्जली टर्शरी केयर बेस्ड, और उसमें जो मेडिकल एजुकेशन के थ्रू जो हमारे बच्चे आ रहे हैं उनको इस बारे में एक्सपोजर नहीं है, क्योंकि फैमिली फिजिशियंस मेडिकल स्कूल्स में नहीं पढ़ाते हैं।
राइट।
फैमिली फिजिशियन कम्युनिटी में होते हैं, वहाँ के जो लेक्चरर्स प्रोफेसर सारे स्पेशलिस्ट हैं, तो उनका एक्सपोजर बहुत कम होता है फैमिली मेडिसिन को लेके, फैमिली फिजिशियंस को लेके। तो वो थोड़ा चैलेंजिंग था, लेकिन इसके ऊपर हमने एडवोकेसी करके काम किया है। जो नेशनल मेडिकल कमीशन एक्ट बना हमारा, जो मेडिकल काउंसिल ऑफ इंडिया, उसे हटाया गया। उसके सेक्शंस में अब यह आया कि फैमिली मेडिसिन शुड बी गिवन प्रायोरिटी। इट इज़ ए मैंडेटरी मैंडेट ऑफ द नेशनल मेडिकल कमीशन एक्ट। फैमिली मेडिसिन शुड बी taught at all medical schools in India, ऐसा है।
Right.
And now all recent new aims, if you know, there are 20 new aims in India after the Delhi one. And all these new aims, at least 6 of them have started MD in family medicine. In Mumbai, D.Y. Patil Medical College started.
Yes.
Then there are other medical colleges like CMC Vellore, St. John's Medical College, Calicut Medical College. They have all started separate course for training family physicians. And this is a new trend happening in the last 5 to 10 years because of our efforts that we started 10 years back.
Wow.
So that is one change. And then these specialized trained family physicians did not have any role in the public health system. जैसे गवर्नमेंट की नौकरियां होती है तो उसमें स्पेशलिस्ट की जॉब्स आती थी, बट फैमिली मेडिसिन की जॉब्स नहीं थी। तो हमने उसके ऊपर भी एडवोकेसी की, तो उसके ऊपर अब काम हुआ है। नाउ यूपी गवर्नमेंट, वी आर सिटिंग नाउ इन नोएडा, नाउ द यूपी गवर्नमेंट इज रिक्रूटिंग देम एज ए स्पेशलिस्ट थ्रू देयर पब्लिक सर्विस कमीशन। एंड अभी लास्ट 2-3 बैचेस में एटलीस्ट 20-30 लोगों को रिक्रूट किया गया है एज ए स्पेशलिस्ट, एंड दिस विल हेल्प strengthen the rural health system of India.
Yeah.
You know, out of cities, if you know,
Correct.
we all have challenges,
of course,
bigger
of course.
challenges.
Yes.
And these doctors who can do many things in the society, in the community, they are more helpful than any one specialist in the community, in the rural areas.
Yes.
So these challenges we have overcome, kind of we are still trying to work on.
Correct. So would you say that India's healthcare policy is moving in the right direction to provide primary care?
Yes. If you look at National Health Policy 2002, we committed that at least 25% of our medical graduates will become family physician. 2017 National Health Policy is again emphasized on it, and we are now working with NITI Aayog, we are working with Ministry of Health, and all of them have now kind of agreed that now this is the direction we need to move in because of Ayushman Bharat program, where we get insurance of 5 lakhs. Which is, you know, currently for, you know, 40% of population, poor people. Now they're trying to expand to elderly. Now, if everything goes to hospitals, only on hospitalization, and there is no interface of family physician, it would be very expensive to sustain financially this kind of programs for government of India also. So if it is to cover entire 1.5 billion population, we need to have family medicine, family physician interface in between the hospitals and the community society.
Right.
So that is, you know, what we are moving towards. So I think it's going great for now. Hopefully we become better health system over a period of time.
Correct. Also nowadays there's so much rising lifestyle diseases like hypertension, diabetes, mental health issues. How does having a family physician help with these lifestyle issues?
Yes, the area where we are sitting now, all IT workers, and we know that our IT workers are giving support to the entire world, and they're working in US shifts, they're working in UK shifts, they're doing for Middle East, entire Europe. All these people come to me, and they're working in, you know, long hours, 10 hours, 16 hours. They're traveling from here to Gurgaon, coming back, you know, families all working. So it is a very stressful situation for them. And also you are getting many young people. Recently I met one guy who was 32, got diabetes. Another one with hypertension. I asked them, what you're doing? I'm doing night shifts for past 10 years.
Oh,
So it is taking toll on our population, our young people, because of this lifestyle issues, and because both women and men are working, children going to school. There's no time to cook at
yes,
home.
yes, yes.
So there's a lot of trend with home delivery of food. People have stopped cooking at kitchen and eating from outside. So that is again causing diseases, not just of lifestyle, but also of stress.
Yeah.
And we need to guide them properly. And many times these are not defined diseases. I mean, somebody having I'm not feeling well, but you do not know what is happening. You do not know which doctor to go to. And when it is not defined in a particular, because it is not cancer, it is not diabetes, it is not hypertension, you do not know what to do with it.
Right.
And then family physicians come handy in taking consultation, but because we provide care across all kind of problems, mental health also.
Yes.
So many times people, when we ask, do you feel sad? They start crying because nobody asked them. They've not met people.
Yes.
There are no people around to talk about. So this kind of situation we get, and lifestyle is very, very important. We tell them, to sleep properly. I was in Australia 2 years back to attend a WONCA conference. WONCA is our World Organization of Family Doctors. And there I saw everybody was sleeping at 7 p.m. Everybody was running to their offices. All offices would close at 4 p.m. All markets would close by 6 p.m. Now, this is the kind of lifestyle we would aspire to,
Yes.
but we are not able to have that because we are working 24/7 in India. ये सबको 2 शिफ्ट 3 शिफ्ट 4 शिफ्ट में काम करने हैं, नाइट में भी काम करना है, सब भाग रहे हैं. तो वो थोड़ा सा हमें काम करना चाहिए पॉलिसी लेवल भी, पब्लिक लेवल पे भी, कि हमें करना तो है लेकिन अपने बॉडी में, क्योंकि फर्स्ट वी लिव इन आवर बॉडी, फिर अपने जॉब में या फिर बाहर रहते हैं. तो अनलेस वी टेक सेल्फ केयर, इट इज डिफिकल्ट टू सस्टेन सच काइंड ऑफ लाइफस्टाइल.
Correct.
Because we are also burning our lives, our bodies.
Certainly. What you're saying is very true. But that now with telemedicine and digital health, what do you see is the future of family medicine?
It would become better because family medicine is all about connections, connecting with people.
Yes.
So anything that connects, WhatsApp is connecting families, and then telemedicine is connecting people. So it has become easier to, if you want to consult a doctor now in India, you can consult now itself. Whereas in Canada and UK, the waiting time is 3 days, 4 days. Even if you are having cold, by the time you meet a doctor, your cold is over. So that kind of situation we are not having in India.
Yeah.
Thank God. I was in the meeting with the Prime Minister when he convened all associations just before the lockdown. And in that particular meeting, this telemedicine thing was legalized in India, because that we could not write or prescribe something on digital medias, and that happened. So I still remember from COVID time to now, it has transformed our relationships with our patients and communities.
Fantastic, doctor. So finally, is there any advice you'd like to give to young doctors who are considering a career in family health?
Yes. I see many doctors, young doctors I've met through my professional leadership. We work with the Medical Association students of India. And I've seen many students, very bright, all our younger generations are very talented people. But what is happening is our system is not supporting them, enabling them. Why? Because if you look at, medical profession is different. You would have never heard of any doctor getting any package or a campus recruitment from, this profession. Nobody is getting a job of crores from AIMS, irrespective of what level you are at.
Yes.
So there is no campus interview for anyone. Now you have to find your own pathway.
Right.
I'm talking about medical students. And the only pathway is, through entrance system of NEET, postgraduate NEET, super specialty courses, and it is very interest oriented, very restricted. It gets into, converges more and more, and it's very difficult to rise and get through. And all our youthful years you are wasting and just with books, sitting in rooms and kind of things. Whereas you can utilize this time going to the community, because you are a licensed doctor after your MBBS.
Yes, certainly.
You are a licensed doctor.
Yes,
and you are not going into community, you are preparing for entrance examination, for doing your MD, for your cardiology. If you spend same 10 years in the community, you'll become rich. I know many
And
people.
you'll gain the most important thing, experience.
Experience.
Yes.
So that training program and that experience you can never, compare, because the longitudinal experience, you can never learn that at a tertiary care hospital, because
Never,
this is very
yes.
different. This is a different context of practice, talking with healthy people,
Yes.
who do not come to the hospitals, because
Correct.
we do not talk. It is very paternalistic in the hospital system. Here the patient is more empowered. They can ask questions. You have to convince them. You have to treat them. Once they are fine, then only they will come back to you. So that learning has to come. And how do you run this kind of small business? I'm not talking of terms of profit making, but to be able to run this kind of system, you need to learn certain things which is not taught in the MBBS course.
Correct, certainly.
So family medicine is one area where, without much of investment, I can sit with my stethoscope, torchlight, and BP instrument, small room as small as this, studio, and you can start your practice. You don't need expensive instruments, expensive machinery, expensive softwares, anything, nothing.
Correct.
You just start, and then you start helping people, and then you are helped in that process yourself. And that is the biggest thing I see advantage in family medicine. You also get a lot of respect.
Of course. So, Dr. Raman, this has been an eye-opener for me, really. And I certainly now understand the importance in my family of having a family physician. There's so many things that I didn't think of. So, I would like the final words to be from you as to what advice you would like to give all the other families, all the families that are there, that why they must keep a family specialist, must have a family specialist with them.
So, in every domain of life, you need some guidance. जिसको बोलते हैं ना, गुरु होना चाहिए. गुरु तो इज अ डिफरेंट स्पिरिचुअल कॉन्टेक्स्ट, लेकिन सबको लाइफ में कहीं ना कहीं कुछ गाइडेंस चाहिए होती है, कुछ मेंटरशिप चाहिए होती है. और वो मेंटरशिप आपको थोड़ा सा हेल्थ सिस्टम में वो ब्लाइंड फोल्ड है, क्योंकि जब आप इसमें एंटर करते हैं तो आपको कोई गाइडेंस नहीं मिलती है. और दूसरे इंडस्ट्री में तो थोड़ा सा कस्टमर केयर वगैरह भी है कि आप बैंक में, फ़ोन कंपनी में फ़ोन करके, अपने कंज्यूमर ड्यूरेबल्स में आप फ़ोन करके कुछ सपोर्ट ले सकते हैं. इसमें कोई अपने फ़ोन नंबर भी नहीं देता है. इसमें आपकी टाइमिंग्स भी फिक्स्ड है कि मॉर्निंग में ही आना है. अगर आपको बुखार रात में हुआ तो आप क्या करेंगे? तो आपको एक ऐसा पर्सनलाइज केयर प्रोवाइडर चाहिए, पर्सनल कोच जैसा, जिसको हम बोलते हैं फ्रेंड, फिलोसफर एंड गाइड, जो फैमिली फिजिशियन का जो कोर आप बोलें यूएसपी है, फैमिली फिलोसफर एंड गाइड. तो that if you can develop, if you see old movies also, and many times family physician is like a family member.
Yes.
जो हम आपके यहाँ कौन में भी किसी न किसी मूवी में आप देखेंगे कि एक फैमिली फिजिशियन भी होता है, उन्हीं का फूफा ताऊ कुछ, and that person is always kind of a family member where you take advice from, and so normally it has become कि कोई family friend is a family doctor, but nowadays family medicine is a structured specialty, is a structured training, and having a family medicine expert, that person will treat you differently from a hospital, because that is a continued relationship. If that relationship is broken, the doctor is also not benefiting out of it. In hospital, it is a transactional care. Once you go after operation, you never meet the doctor in your life.
Yes.
But family physician, you can for everything. Doctor, अभी ये हो रहा है, मैं क्या करूँ? Family physician also does not mind. In my WhatsApp, I have around 20,000 numbers of my community.
Yes.
हमें ऐसा लगता है कि सब तंग करेंगे, ऐसा नहीं करते हैं. तो लेकिन कभी किसी का रिपोर्ट आ गया, किसी की कॉल आ गई, तो वी वुड लाइक टू हेल्प. कि छोटी प्रॉब्लम्स में हमें क्यों इतना ज़्यादा उसको कॉम्प्लिकेट करना.
But we've all been there, the times of an emergency when there's nobody there.
Yes.
and I always think that if we had somebody who was exclusively for us, or our family physician who knows us, and whom we feel comfortable with, we can call at any time. So I think thank you so much, Dr. Raman. It's been wonderful.
Yeah, same here, ma'am, and thank you very much for coming here.
Thank you. It's my absolute pleasure.
We have been all your fans, and you are a public figure.
Thank you.
An actress. You talking about family medicine, family doctors. It will bring more awareness.
Yes, I certainly hope that this podcast that we've done today does bring an awareness to all the people watching, and we realize the importance of having this person in our lives.